We are ready. Okay, we're gonna pick up kind of where we left off. How should I frame it? Um, it's interesting. It's just today really is starting to look at the specific antibiotics. There's a little bit more background information. This PowerPoint and the way the book does it is a little different than the Nestor book, but all the books basically cover the same material. It's a question of how thoroughly they do it, or to my liking, so to speak. But it's above my pay grade as to what we cover. I just do it my way. Nevertheless, here we go. So this is kind of where we left off, more or less. And first of all, you have to understand there's a lot of decision making that goes on in antibiosis for basically being able to pick what are the most desirable ones to utilize. Again, the big issue, bacteriostatic versus bactericidal, allergies, overall health, the specificity, uh, preferring something that's narrowly targeted than broad spectrum, at least over time, uh, different considerations with underlying diseases, pregnancy, uh, all sorts of types of things. And again, that was the talking point before about understanding other medications have impact on these things as well. So that's all of it. And they gave you an interesting case with regard to these things. It's not necessarily straightforward. Okay, allergy to penicillins really limits what you have to do. And now you have liver and kidney problems that are associated with it. Parenteral, para, beside, enteric for GI means not oral. Parenteral can be anything that isn't oral, okay? If you want to think of it that way. I mean, you can make an argument that suppositories are, which are utilized a fair amount, are still variations of enteric, but I don't think so because they're absorbed in the lining that are there. And then again, cancer patients that have severe systemic candida infections. Candida is very, very common. We'll get to that a little bit. It's a yeast or fungus. It's bear mentioning that's the causative organism for one of the most frequent things that everybody sees in medicine: vaginal yeast infections, Candida albicans. Albicans because it's white. When it grows, when either you see the discharge is whitish, or sometimes the appearance will be whitish, or certainly culture-wise will be whitish in nature. But it can become systemic because I take immunosuppressants, and the one I was taking previously, which is a little bit broader based, caused me to periodically have a condition called thrush, which is oral. And you're going to see that. And what it is I mean, it's like you think everything is going wrong inside your mouth, but it's an overgrowth because about a third of us have it normally in our mouth, and it just normally it wouldn't overgrow. And you basically have to do a lozenge, which is effectively topical. So I take them like 5 times a day. Not fun. Sitting there, it's okay. So when you look at zones of inhibition, one of the things you might look at is not the size, is whether it works or not, but then you look at therapeutic index. It's really being the critical piece that's there. So that's just some of the stuff that we've been looking at, more or less. And now we're going to get into what's going on. Okay, the whole idea, and again, the watchword is selective toxicity. Kill or inhibit or somehow interfere with the microbe from replicating or causing damage without disrupting host cells. There are they're all different because you have prokaryotic cells, eukaryotic cells, eukaryotic cells. Viruses aren't cells at all. Now we have a whole subset of problems interfering with certain kinds of enzymes that are part of synthesis or assembly, destruction, etc. So that's sort of the launching point. And the first thing we always start with are going to be the penicillins, the cell wall antibiotics, because they're the best choices if you can use them without allergy, because they're targeting something we don't have in our cells, peptidoglycan, of course. So the bacterial cell wall, penicillins and their cousins, which you'll see are called cephalosporins. We don't have the peptidoglycan. Now, on the flip side of that, we have very, very limited usages for something that's common to all living things, which is a cytoplasmic membrane. So, as you might suspect, something that targets the cytoplasmic membrane is rarely used. Only in extreme cases do we typically use cytoplasmic membrane drugs that target it, because if it's going to rupture that membrane, it's going to rupture your membranes. That again is something, the agent that we use most commonly, we use topically because it's so severe. It's called polymyxin B. That's one of the three things in triple antibiotic ointment that are there. It occasionally has to be used for infections that are life threatening. We'll see that. Okay. So selective toxicity is much more difficult when we're treating eukaryotic pathogens, protozoans particularly, fungi particularly, and unfortunately, because of the reason that is so, is they're the same kind of cells we're made of. Whether it's a single cell or multi-celled entity doesn't matter. Same kind of cells, same kind of targets that are there. So the goal to disrupt the structure or function to the point where it can't survive either directly by something that's toxic to it or indirectly by allowing your immune system to do its jobs. So here are the different categories. The two biggest categories are the really effectively the first two of this one here and this one here, of the first two of the three. So the first bullet, cell wall antibiotics, number one in the hit parade. Typically your best choice if you, in the absence of allergies. We have a lot of input for inhibition of nucleic acids. There's one particular family, I talked about it briefly last time, called Cipro or ciprofloxacin. Ciprofloxacin, that's the category. It's not the name of the category, but you'll see it shortly. And protein synthesis, the other big category. Those were effectively the first two that were isolated. Drugs that affected protein synthesis with that streptomycin from Selman Waxman being one group, and there's a lot of subcategories in it. The other are the cell wall agents where penicillin sprang from. Yes, cytoplasmic membrane, and a real interesting player, inhibition of folic acid synthesis, a really important agent today that's been around for a long time. It came from, if you remember in the sort of the initial discussion last time, that prontosil, that dye, that enzymes broke up and it created this category we sort of collectively called sulfa drugs. And interestingly, they're more really less antibiotics and more antibacterial, though people talk about them the same way, and I don't really want to make that distinction so much that are there. But folic acid is something that bacteria utilize a particular pathway to synthesize their nucleotide bases, the A's, the T's, the G's, the C's, the U's, all that good stuff, just like we do. The trouble is we don't have a folic acid pathway. We can't manufacture it. We've got to ingest it. Effectively, it's in the category of B vitamins. It's very important. It's extraordinarily important prenatally. It's something you probably should learn about if you haven't already. That was one of the big problems with neural tube development issues in the past until we realized that women were not getting enough folic acid during pregnancy, and all of a sudden, magically, prenatal vitamins stopped the problem. So many kids were being born with disruptions in the neural tube, and it created something called myelocele and myelomeningocele. If you look those up, you'll see about folic acid absence or limitations prior to prenatal vitamins. Very, very interesting. So when I was a kid, we became more impactful that we began to learn about that. So yeah, they use this illustration. They've had this illustration in this series of textbooks forever. Don't love it. Okay, I don't really love it, but it's showing you in general this category where you're going to see these are all protein synthesis. There's a bunch. The Z-Pak, another agent that's used less frequently, but I've used a lot, called clindamycin. New ones called Cindercept and plurobutylins. We'll get into all of those. It's not good. And additionally, remember there's the two, the large and the small subunits. So I group them together. You don't just have to know they work on protein synthesis. They work on proteins. I don't care whether it's 50S, 30S, whatever S. Aminoglycosides, gentamicin particularly important. Again, root usages are relatively limited. Tetracyclines and glycylcyclines, much more important. Linezolid, another one that's relatively new. These are all protein synthesis. Folic acid, we're going to look at this. Oftentimes we call them combination sulfates. In the lab, you might have used that when you did the Kirby Bauer test. It might have said triple sulfide with 3 S's on the little disc, am I ringing a bell? Or SXT, not ringing a bell. So it's called, I love this stuff. Big player. Membrane, pretty limited. Polymyxin, known as colistins, daptomycin, one that's used more commonly. The quinolones, these are involved. This is where cipro or ciprofloxacin comes from. They involve a specific enzyme called DNA gyrase, and it's the winding and unwinding. Remember, if DNA can't unwind, it can't replicate or do what it has to do. You're interfering with a very important pathway that's there. Rifampicin, we'll talk about in the context, very powerful, really one of those drugs of last resort choices. And then the big category, the original category, probably why we hear so much about it, penicillins, their cousins, cephalosporins, carbapenem, one of the ways we define certain kinds of superbugs these days, vancomycin, another big player that we overuse, bacitracin, which is topical, isoniazid, I don't know about phosphomycin that much. Isoniazid, which is an anti-TB drug that's so frequently used. So there's a whole bunch that are in there. I probably told you this in A&P. I'll tell you this. I always tell you it in micro. For you going into the nursing sphere of influence, okay, when we're going to a nursing program, here's what this is what I was told to do when I was a resident. So when I was a medical student, and I got it, and I'm with these other medical students, and guys who were first year residents, when I was doing a rotation when I was between junior and senior year in medical school at the Vets Hospital in Richmond, Virginia. And I said, and it's a voluntary program for me. I'm getting nothing out of it. I'm paying for the experience. And guy pulls out a notebook. Every time he sees a patient, I see him writing a notebook. I said, what are you doing? He says, oh, what I do, every time I get a diagnosis, I put it in my notebook. And said, every time I get the same diagnosis with a patient, because every patient they see, they have to go through the history of the physical, I put a check mark. And you learn which ones, and whatever ones have the most check marks, you better learn the most about it. Same is true for nursing with medications, as well as diagnoses. Okay? You have to, you surely are going to have to do med cards. They still do med cards? Ask your mom, they do med cards? Where? You ask her today. You'll see if I'm right or not. Med cards are this. Med cards are where you, every time you have a new patient encounter, you write down the medicines, you do a card on effects, side effects, administration, blah, blah, blah. Very useful. That was SOP for nurses. May I remind you that my first wife went to nursing school starting in 1968. Okay, and it was 12 about that, and she was teaching and all those things. She was one of the early BSN graduates from Slippery Rock when they started the program around 1980. And have some kind of nursing honor society she went into. And she barely got through nursing school at CCAC here downtown, the Allegheny campus on the north side by Stadium. So you do the same thing in that little notebook. What the name of the drug is, put a check mark. Whatever one has the most check marks, whatever ones, learn about it. Doesn't have to be antibiotics. The two that I take for blood pressure, losartan and amlodipine. Everybody takes it. Everybody. Atorvastatin, the anti-cholesterol stuff. I don't necessarily think it's a great idea, but I think there's more side effects than people count on with it. But you know, those are ones you need to know most about. Enough of my sermon of that part. So here they are. Cell wall. Penicillins, we'll get into it. These are the original penicillins, basic penicillins. Not by number, they did them by letter, don't know why. Penicillin G and V. Then penicillins that became these varying kinds of substituted penicillins. Clavulanic acid, there should be an O, not an A, I think there, is an important adjunct that's utilized particularly with amoxicillin. That combination has become a very effective agent for certain kinds of infections that are relatively resistant. It's not without problems. It has a very famous name. It's called augmentin, and you do need to know about that. You'll see a lot of augmentants. Cephalosporins, these are called semi-synthetic penicillins other than G and V. Everything in the cephalosporin category has to do with quote unquote generations. It's interesting that these two agents, penicillins and cephalosporins, they both come from very, very common fungi that are related to one another, though distinctive microscopically. What they have in common in these agents that have been extracted from them is something called a beta lactam ring. The beta lactam ring is frequently the target for these antibiotics. There's a lot of confusing terminology, but so collectively we see a lot of these, you'll say beta lactam agents for the antibiotics that target this ring structure, which you don't have to know the chemistry of. That's associated with penicillins, PCNs, and cephalosporins. I'll just put cephs. I don't write that well anyway. So it's a really important player. The chemical structure has areas where you can tinker with it in the laboratory. So that's where they call these are semi-synthetic drugs, whether they say semi-synthetic penicillins or different generations of cephalosporins. And we'll look at that because it's a little more thorough on the Nestor PowerPoint when you look at that. Again, you don't have to know the chemistry, just the idea behind it. Carbapenems are older agents that were interesting, that they were penicillin type agents, cell wall type agents, worked a little bit differently and had a little better spectrum of activity on gram negatives. But there were some problems that were associated. So we don't use them as much, but they're part of what defines certain superbugs, bugs that are very, very hard to treat. Bacitracin topical, isoniazid for tuberculosis. And again, I don't know enough about the phosphomycin, but Vanco, I do know. Vanco was the original drug of last resort. It does target the peptidoglycan assembly. It has absolutely no effect on gram negatives, none. But it was the drug of last resort for gram positive. When someone had a staphylococcal infection that you couldn't deal with, you use Vanco. Okay. If you go to a nursing home, if you work in a nursing home, you're going to have a ton of people on Vanco. Okay. You have to do blood levels periodically to see how it is. What happened was originally, and it doesn't work particularly well orally, years ago, when people had something similar to C. diff, which was called Enterococcus faecalis, which is a normal bug that we see it's a cousin of Streptococcus that's anaerobic, that's located in the colon. And used to cause a lot of colitis infections. They gave people a lot of Vanco for that. And unfortunately, what happened, it developed resistance, we think was plasmid mediated. And it was called, you'll hear about it a ton, because if you work in a hospital, you'll hear about these two awful GI things that happen in long-term care patients, and patients in the hospital, and patients who are on strong antibiotics, called C. diff, which you already heard about, and VRE. And they play ping pong. You get rid of one, the other one shows up. It's awful. Diarrheal diseases, incontinent mess, leads to urinary tract infections, blah, blah, blah. All that bad stuff is going on. With VRE, so they found out you can't use Vanco for this. So you have to be very, very careful with using vancomycin. So much so that they started to see resistance in Staphylococcus, and if they come up with a consistently vancomycin resistant Staphylococcus aureus, now we have a game changer of monumental proportions, a true superbug that you can't kill. So whether this surprises you or not, or whether I told you before, it bears telling again. We knew about this early in the 90s, to the point where while I walked into the operating room at St. Francis Central Hospital, which is where the Penguins played, where that building was destroyed, and they built whatever they're calling it now, PPG Paints Arena or whatever it is. And they went in there, and I'm going in there to do an operation, and I'm sitting there with a clipboard, read this and sign this. Please be aware the pharmacy will no longer fill prescriptions for Vanco that you write unless you can document you did X, Y, and Z. Unless you can document other forms of treatment that you've administered to the patient to treat staphylococcal infections. It's naive to think that doctors have carte blanche to prescribe anything they want. It is not the case. Everything is governance and things like that. They were developing tons of resistance that had to be addressed. This was just 30 years ago, I would dare say. Last time I operated anybody, was 2000. Just to give you an idea. So, onto these, we're going to go back and look at this, but I'm giving you some generals. This was Selman-Waxman, aminoglycosides. Again, you don't have to know any of these things about it. The parent was streptomycin. They played with it. You'll see things like tobramycin, gentamicin, kanamycin, neomycin, which is so powerful it could not be used internally. It had to be used topically. It's the reason why diabetics shouldn't be given triple antibiotic ointment for wound care or skin care problems, because the neomycin causes a powerful allergy in diabetics. A lot of people don't know that. And treated a tons, more than half my patients easy with diabetics. So that's why they made bacitracin ointment or Basaglant or different ointments that were utilized for that purpose. Just saying. In that category, there's something called gentamicin, one of the few agents that's relatively consistent dealing with one of the hardest things to take care of in a hospital environment, Pseudomonas aeruginosa. You work with it in the lab. It's common. It's a soil bacteria. It's an interesting and oddball aerobic gram-negative. It came into the hospital. It's everywhere. And it's scary. Because I always made sure the students tested that with the Kirby-Bauer test, because it pointed out how quickly nothing really worked. Maybe one thing would work on that, because we probably had some old streptomycin which we don't use anyway because of all the side effects that were associated. That whole category is very limited. Effectively, you have to use it by injection, intramuscularly or intravenously. Consistently, it causes toxicity to the kidneys. Every other day, you have to monitor kidney function. You do that by monitoring two things. I don't know if you did the renal unit yet or not. You'll learn about these. They're called BUN and creatinine, blood urea nitrogen and creatinine. When those levels goes up, your kidney function is going down. Your kidney's supposed to clear those with a relatively small amount left in your bloodstream. When someone's in kidney failure, those numbers go off the chart. That's a ticket for intensive care. You're looking at someone who was there because of that, not because of the medicines. But so you have to test that. The other thing it does is called ototoxicity. It affects your hearing. So that's why we don't use some of these. Side effects are significant. Those aren't allergies, those are side effects that happen. Why it targets that, we don't know. Again, it's targeting a ribosome. We have 70S ribosomes in all of our mitochondria all of the time. So whether that's it or not. And the same thing. So we'll look at that category. Tetracyclines. The third major category that was isolated from soil bacteria was called terramycin at the time. It was from that same Streptomyces. They just gave it a different name. So back in, I'm going to tell you, the mid-50s or so, all of a sudden they thought this was it, the wonder drug. They were giving it to people who had a cold, thinking it was going to be the cure for because they had no idea that colds were strictly caused by viruses. Everybody was getting Tetra. And what was the interesting thing about it, it was effective against gram-positives and gram-negatives. The reality is not very well. It doesn't do very much for staph or strep at all, which are much more common agents. Even though technically speaking, it's broad spectrum. They've tinkered with it, and it's become, with a couple of entities called minocycline, known as minicin, and vibromycin, which the name escapes me as to the generic, but commonly referred to as virus, which is used a lot today. I mean, amazingly, where it doesn't work on staph and strep, that could be a drug that you could use for a severe infection like Rocky Mountain spotted fever or Lyme disease. It's interesting how we can't grade it based on whether it's common or uncommon. It has a lot to do with the specific organism and how well it's addressed. It's even effective in mini doses, and that's one of the sometimes they're used for acne medications. People can be familiar, as is erythromycin. So a lot of times what we call subclinical doses still are effective in dealing with certain kinds of conditions. So what we found out right away, they were giving it to everybody forever. staph infections, strep infections, didn't get better. So again, a lot of times in the old days, they'd find a wonder drug and they'd err on the side of overusage. Glycol cyclines are cousins of these that are being more effective recently. I don't know a lot about them as yet. This is the erythromycin family name. It's called macrolides. Again, from that same soil bacteria. It started off with erythromycin. That was the first one. The beauty of erythromycin, this category is, be aware of it, the drug of choice for penicillin allergic individuals. I'll reiterate the point. When you have in a hospital or in medicine or in science an accepted way of doing things, you better have a good reason if you don't do it that way. If it's the drug of choice, you have to use it unless they're allergic to that. Okay, good reason. Okay. They had a horrible side effect and nearly died. Okay, good reason. There has to be some documentation or justification for not doing it. Erythromycin initially worked, but you had to take 4 pills a day, 1 pill 4 times a day for 10 days. Hard for compliance. Inevitably, it caused diarrhea. Real significant problems because people were reluctant to take it and because of the diarrhea. But it was important. It got tinkered with in the laboratory, and voila, Pfizer Labs, it's a reward for only making penicillin during World War II, my feeling. I often use this expression. You may have heard it. No good deed goes unpunished. It's like you do somebody a favor and they stab you in the back. When you get to be 72, you'll realize that. Everybody, we're at presents, May 10th, 72. I'm still waiting for those wireless headphones with the new updated. I did that to one of my classes. You know what they did? They went to Five Below and got me earbuds. Shilling for presents. Do any of your other teachers do that? Probably not. Just saying. Nevertheless, so Pfizer Lab, in this case, a good deed got rewarded. They tinkered with it. They found something that worked. You only had to take I had to take 6 pills, 2 the first day, 4 the next, 1 each of the next 4 days, total of 6 over 5 days. Perfectly effective for 10 days, wonderful compliance, and didn't have the GI problems that were associated with it. Voila, the Z-Pak was born. In the pharmacy industry, they talk about billion-dollar drugs. That's one. The other one that Pfizer came up with that has made them a lot of money is called Viagra. So, I mean, they got rewarded for all that. So it's fascinating with regard to that industry. The pharmaceutical industry is very complicated. I'm going to tell you, around 20 years ago, we reconnected with an old friend. My wife did. She had remarried, and her husband had retired from a big pharmaceutical company. That was the issue that ended up putting Martha Stewart in jail for lying to the FBI. It was a whole big thing because there was a drug that was coming out. The pharmaceutical company had put hundreds of millions of dollars in what they call a launch, hire new people. And all of a sudden, the drug got a bad report from the FDA, and they had to stop it. I mean, he's telling us about how many people lost half of their retirements from things like that. So there's a tremendous amount of money that's involved in all of these things, and I don't want you to think that should compromise anybody in treating patients, but the reality is money plays a role in a lot of things we do. Clindo has been around for a long time. It has a very limited subset. Okay, clindamycins. Okay, we're in a fancy name for the category are called lincosamides. It was lincocin and clindamycin. I use a lot of clindamycin because it was very effective. It had great penetration into bone, and so when you had bone infections, that was part of it. It also penetrated, you might remember the name glycocalyx. The glycocalyx is that shell of sugar that bacteria, well, our cells have it too, but really in bacteria, And what happens around orthopedic implants, pins and screws and plates, staph epidermidis makes that, and it's very hard to penetrate if there's an infection. Clindamycin. The trouble with that is severe diarrhea. You're seeing a trend with these protein synthesis drugs. The biggest single problem with antibiotics and their usage, not allergies, diarrhea. And that is a side effect. The distinction, allergies are because of an inappropriate response of your immune system. Side effects means it has targeted a particular system and damaged it. And most of the time it's gastrointestinal. So, and that's what people, because they'll tell you they're allergic to it again. And you have to ask, what gives me a terrible headache? That's a side effect. I get terrible indigestion. That's a side effect. I vomit. Okay, sometimes you have to deal with that. It takes medicine. And then these are some of the newer agents we'll get into. Most of these were agents that were designed for the purpose of dealing with MRSA. The big problem in this category, with the exception of aminoglycosides, and Synarcid, the medications in this area are bacteriostatic. So they would normally not be first choice if you had a choice. That's, again, allergic to penicillin. When you go back and you look at cell wall, they're nearly all bactericidal. And that whole category are compromised here by those three words, allergic to penicillin. So there's a lot to it. I've had patients where they said they were allergic. What happened with penicillin, rash, etc. Something was allergy. But I found out that they had taken, I call up their physician and say, have they ever had any reaction to cephalosporins? No, okay. So, and of course, when you have that conversation, you document it. I spoke with Dr. So-and-so, who is this person, blah, 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 family physician, whatever, internist, diabetologist, said they did not have an inappropriate or untoward response to prescribing. Thank you very much. Sulfa drugs interfere with folate metabolism by blocking enzymes required for the synthesis of this agent. You have to know that. And DNA, RNA, and amino acids. So they use a combination, sulfamethoxazole and trimethoprim. Technically speaking, they're antibacterials. They call it interferes with this pathway that I'll show you later. And again, you don't have to know. It blocks two enzymes from making the folic acid. And therefore, the folic acid can't make all this good stuff. This is the one I told you about before when we talked about metals in those different types of chemical agents that you could use. Silver sulfadiazine, so it's a combination of silver and a sulfa drug, and it is the absolute best topical agent in the world and has been forever for burns, called Silvadene cream. The fluoroquinolones, that's the Cipro. These are all in that category. It's a matter of preference that are there. They're even using it. I took one, and I just named it, to call it. I had some kind of pneumonia that they put me on that particular Avenex. I'm just trying to remember. So it's a base that also has diarrhea as a problem, but this is typically bactericidal. So I had a 10-day course of this and made it through 9 days before I couldn't take it anymore. Yet I survived. And then lastly, even though I can't tell you where it targets it, I think it's RNA. Rifampin or rifampicin is our first choice judge for tuberculosis. We'll get into the problems associated with anti-tubercular drugs. Tuberculosis drugs are very, very harsh and powerful, and you have to take them for a long period of time. When you're treating active tuberculosis, you're looking at a year of antibiotics, and not one, at least two, that you rotate and change. So it's a long course of antibiosis. It's not easy to deal with. I always tell this story that if you go back, and it was a cell wall agent that was used for tuberculosis. They used to. I don't think they use it now the same way. It was called INH, capital I, capital N, capital H. And I had a student back in 06 over at Chatham, where I was doing all the education in micro for Shadyside School of Nursing. And she would alternate between A's and D's on any type of thing she did. I'm like, do you only study half the time? And she goes, oh no, I've had to take INH every day, and some days I just can't focus. Did you ever think of telling me you were having a problem because of a medication? No, I didn't want to do that. Ooh. You know, I had students there whose dads were having the same heart attack every time there was a test. You know people like that. You all do. There's an old TV show called MASH. Is it ringing a bell, anybody? Okay. Very, very famous. Still the most watched TV, non-sports TV episode of all time. The final episode of MASH in 1983. And the Klinger character, who tried to get out of the army by cross-dressing, was constantly giving excuses to try to get to be sent home. Mother dying, sister pregnant. Father dying, mother pregnant. Everybody on one side of the family dying, everybody on the other family pregnant. That's the student whose test is having I'm having it. God. I wrote that book. Did I mention I used to take calculus tests for pre-med students when I was in college? Did I tell you that story? Yeah, I figured that. That was before we had photo IDs. I am not available for sale. Just saying. Interesting. Colistins, membrane, particularly effective in gram negatives. This daptomycin has become a choice for a very specific area we're going to talk about that are called extended spectrum beta lactamase resistant drugs. We'll go into that. Broad spectrum. Okay. Effective against basically gram positive and gram negative. Doesn't speak to how effective it is. Narrow spectrum, limited. Again, there's mostly gram negatives. The original penicillin was narrow spectrum and very, very susceptible. It really just worked on gram positives and very easy to kill gram negatives like syphilis and gonorrhea. And so they've altered it. That's called semi-synthetic over the years. And so all that to try to overcome it. So here you can be sort of looking at some of the things that they use. I don't think this is terribly important. We're going to deal with it. As we look at disease, when we get to respiratory diseases, we'll look at these medicines. When we look at, this is gonorrhea is effectively diseases in the urinary tract. These are immune system plague. Salmonella is gastrointestinal. Gram positive, staph and strep. There's a whole lot of things that we can use on those, as you can see, which is good. This might be interesting here. That's what I told you before, rickettsia, which is one of the agents that deal with Rocky Mountain spotted fever, which we actually see more here than they do in the Rocky Mountains because it's tick. We have more ticks. Tetracyclines, which don't work particularly well, but on chlamydia, the most common bacterial urinary tract infection, sexually transmitted bacterial infection. Penicillins don't work on that. I don't know why they even put that in there. Okay. They don't have a really distinctive cell wall. Okay. Tetracyclines in the Z-Pak are much more effective against that. The only good thing about chlamydia is it's relatively easily treatable. I'll give you the whole spiel on that. So let's look at what's going on here. Let me see what the time is. There's so much to share with you about that. My daughter-in-law is sending movies to the grandkids. Look at that. Don't start. Don't start. So we have, I'll give you sort of the lineage. When penicillin first came out, okay, they used it for everything. And they rapidly found out it worked well for gram positives, not so well for gram negatives. So penicillin G and penicillin V, relatively narrow spectrum. The difference is penicillin G had to be administered by injection to be effective. They used it orally. My former father, who's now deceased, had actually used that for recurrent infection in his leg. Penicillin V, orally active, is called Vicillin K. I used to have one of my dentists used to prescribe that whenever she did like extractions. Because it worked effectively against streptococcal organisms. Very, very narrow in general. As soon as they began to see that, they started to tinker with it. What was happening? The bacteria were changing. Well, the first thing they did was they tried to broaden the spectrum. So by broadening it, even though it's not in sequence there, they basically added something with an amino group to try to target more gram negatives. So that's where ampicillin came in. Worked better on gram negative. And the difference between ampicillin and amoxicillin, which are effectively the same, is a subtle chemical change that was done in the lab. This one was much better by injection, though I remember as a kid taking it oral. Okay? And they came up with a much better orally active form. So orally active aminopenicillin very famously became amoxicillin. And amoxicillin got a lot of play, most of it coming from connection, the University of Pittsburgh. That was where they studied at Eye and Ear Hospital how to treat children's ear infections and found the most effective drug for it, assuming they weren't allergic, was amoxicillin. And we'll get into that in respiratory diseases specifically, how it's effective. So I got that little nugget coming up. It's the Pittsburgh connections. I have been. I became Western Pennsylvania Pittsburgh eyes over the last 50 years. But maybe the most important Nick basketball player, and there's a very limited subset of those guys, is Wilsby, captain. So that's those two. No, okay, they broadened the spectrum. So they were using a heck of a lot of that stuff, and then they began to found out that organisms, staph principally started to morph and change genetically, evolve, whatever word you want to use, and it started to make a particular enzyme that targeted that beta-lactam ring called penicillin. So the target was beta-lactam. Staph plus other organisms, some staphylococci, plus other organisms, made a variant of this that's called beta. They are similar in that they're enzymes. They're similar in that they target the beta-lactam ring. They are dissimilar in the sense that the penicillinase ones are a lot more difficult to cope with. So at that point, and now we've evolved into maybe the early 1960s, late 60s to early 70s, and they started to tinker again with it, okay, where they've started to make methicillin and nafcillin, which were much more narrow. They were specifically targeting what were called penicillinase-producing staphylococci. Didn't absorb well, so you had to inject them. Not used very much now. We used a lot of it. The part that they don't show you on this chart is called, and this is what we used a lot of because they were orally active, oxacillin, cloxacillin, and dicloxacillin. So the orally active members of that category, we were using that a lot in the 70s. Ox and clox and dicloxacillin were extraordinarily popular because you were targeting penicillinase. So again, we're not seeing as much of a use of those that were there. Now, at the same time, they began to find that they wanted more availability for gram negatives, particularly things pseudomonas. Okay, because the aminoglycosides like gentamicin, ear toxicity, etc. They were trying to say, came up with what were called extended spectrum. And so when you hear about ticaricillin, mesocillin, azlocillin, those are known as extended spectrum penicillin. They're important because what happened, the organisms in the gram-negative family began to make a variation of this called extended spectrum.
Here are selections available on Spectrum TV.
Didn't do it. Beta-lactamase. So the organisms immediately start to fight this. And this is one of the problems. We're going to see organisms that deal with that attack with these particular antibiotics by attacking these extended spectrum beta lactamases. So there's another problem there. Well, beta lactamase itself is not quite as powerful in its typical state as penicillinase. So what happened was clavulanic acid was either identified or developed. And what that targeted specifically was the typical beta lactamase. It did a great job of inhibiting it. So what they did is they added that to amoxicillin, as I said before, which was broader in spectrum and very useful against non-staphylococcal organisms, even some staphylococcal organisms that made just beta lactamase. And by empowering it, they called it augmentin. Now you can get it generically in Clavamox. They were using it in veterinarians were using it early on, calling it Clavamox. So augmentin, other than its gastrointestinal effects, so they started using, even adding it to erythromycin as a drug of choice, but the diarrhea was so profound they had to stop using it. I was around when they started using that. So augmentin came to the fore about 1980, I'd say 84, 85, that area of time that were there. There's a whole lot about this. How it works effectively is this. The clavulanic acid nullifies the beta lactamase, and it allows the amoxicillin to work normally. Effectively, is what it does. So it's not dramatically different in the effects of amoxicillin. It just helps us on its way. So, and that's become a staple. A lot of times they'll start people on amox. When it doesn't respond, they then begin to think, because typically you're not testing it with ear infections, then your next step up will be augmentin, and maybe sometimes they'll go into something as a cephalosporin. And next time we'll start with the cephalosporin family and go from there. So thank you very much. We will do that.